I can share my screen. Thank you ever so much for inviting us to speak tonight. This is a session on genitourinary syndrome of the menopause, and I'm Sue Stillwell. I'm the menopause lead for Sheffield Teaching Hospitals. I'm just going to see if I can manage to share my screen. This is always a little bit of an art, so bear with me as we try and do this. And let's go to slideshow. What can you see? Because that doesn't look quite right to me. Can you hear me?
Yeah.
Oh, it's not quite right, is it? Oh,
from the beginning, slideshow from the beginning.
Yeah, that's what I'm trying.
Oh.
It's clicking slideshow. From the beginning there. Let's try that. Sounds like a good plan. Thank you very much, Emma. Right, just to introduce all of us, I'm Sue Stillwell. Many of you may have referred to me at the menopause clinic, which is run at the Jessup. Laura is in the yellow top, and she's a GP, and she holds the certificate, the advanced certificate of menopause care from the British Menopause Society. And Lindsay also holds that advanced certificate of menopause care. They're both GPs and have a really special interest in menopause and lots and lots of experience in menopause care. And we've chosen to speak about genitourinary syndrome of the menopause today. And I know it was mistitled at first. So for those of you who are expecting a talk on straight menopause, apologies, we will field any questions. But we really felt this was an area that is not discussed frequently enough. There are some new medications on the market that you may not have used before. And Lindsay's going to talk about those. And Laura's going to talk a little bit more about primary care and the impact of symptoms of genitourinary syndrome of the menopause in primary care, and how to bring about change in a practice in terms of prescribing. So that's the remit for tonight. We're going to talk about what is genitourinary syndrome of the menopause, what symptoms does it cause. We're going to look at a GP's experience and case and treatment options, and then plenty of time for questions, hopefully. So genitourinary syndrome of the menopause, or GSM, is the new name for what people might well have known as atrophic vaginitis. And it describes the impact of loss of estrogen, not only on the genital tract, but also on the urinary tract. So it tries to bring in the fact that there are estrogen receptors not only in the vagina and the vulva, but also in the bladder and in the bowel. So it's replaced that old term that lots of people didn't really like, but there are still some people who prefer to use a term called vulvovaginal atrophy. And the reason some people prefer that, because it also includes a group of women who are not yet menopausal. And I'm thinking of women who have low estrogen levels for another reason. And that might be because they're breastfeeding, or it might be because they're on high dose progestogens, or they might be on a GnRH analog. So they might have some symptoms, yet they're not menopausal. And I think you'd have to include in that group women who are perimenopausal, because often perimenopausal women, if you ask them specifically, will tell you that they get symptoms pre-period when estrogen levels are low. So this is the kind of slide, the kind of picture that I remember from when I was a student, and then when I did MRCOG, and it tells you that the vagina gets thin. You can look on the left-hand side. This is the epithelium of the vagina when there's no estrogen compared with the right-hand side. So there's a huge difference in thickness of the epithelium, but it isn't just about thickness of the epithelium. Something else is happening. There's less glycogen in the cells in the vagina, and glycogen is what lactobacilli live on. And lactobacilli are what keeps a vagina healthy. It supports a normal vaginal flora. So once you lose your lactobacilli, the pH of the vagina goes up, and you lose that protective effect of the acidity of the vagina. Other things are happening all at the same time. There's a loss of fat from tissue around the vulva, and if you examine women, you'll notice that the vulva often looks flatter. The urethra might become more exposed not only to infection, but to irritation, rubbing and contact. The blood flow to the vagina and vulva is reduced, and that might affect orgasm. So there's lots of things happening here. And I struggled to find a good slide to show you the changes, and this isn't perfect, and I appreciate this. But on this top picture top left shows that the skin looks a little bit pale, and again on top right you can see that the clitoris looks a little bit flatter than you might expect. Similarly on the picture C, but on D this is a speculum picture and it's showing the vagina, and what I want you to see is that it's pale, that it's smooth, that there's no secretions to be seen there at all. You can imagine you'd need plenty of lube to be able to put that speculum in place. And what this is showing us that there is a loss of the corrugation in the vagina, and that area of tissue is called rugae. And these are stretchy areas of vaginal tissue that allow the vagina to expand when somebody is aroused. And the vagina expands by about 30% when a woman is aroused. If there isn't the stretchy tissue there, it won't expand and the vagina will feel short and intercourse will be difficult, and no amount of lubrication is going to solve that problem. Estrogen does though. So this slide shows you some of the symptoms of menopausal changes in the vagina. And it's got at the top vaginal dryness and burning. But actually, I think it's really important to look at some of the other symptoms that are there. Genital irritation, itching and sensitivity are really common symptoms and often get misdiagnosed. These are the women who get treated for thrush or might be given steroids with a possible diagnosis of lichen sclerosis. And then we move on to the urinary symptoms with urgency and frequency and sensitivity when you pass urine, recurrent urinary tract infections. And then it comes down to the symptoms of sex, painful sex, tight sex, dry sex, sometimes being unable to have sex at all. But the reason I like this slide is because it actually puts sex at the bottom. And I think for so long we've focused on women who are having sex and problems with sex that we forget to ask all women about vulval and vaginal symptoms when they're perimenopausal and after. So it isn't just about whether you can have sex. Lots of people can cope without having sex, but if you can't ride your bike or you can't wear your tight jeans or you're uncomfortable sitting for a long time, that's really affecting everyday life. So it's just a reminder we need to be thinking of these symptoms in all women. So where do we get any more information about what sort of symptoms are experienced by women? And this is a study called the REVIVE study, which was real women's views on vaginal atrophy. And it's about 3,500 women, and they looked at women in Germany, in Italy, in Spain, and in the UK, and asked them to tell us what symptoms they had. And we're all familiar that about 70 to 80% of women have hot flushes, but are we aware that 80% of women have vaginal and vulval dryness? The UK women, about 40% had vulval irritation, and that was a bit higher than the other women. 66% said that GSM affected their ability to enjoy sex, it affected spontaneity, and it affected their ability to be intimate. So it wasn't just about sex, it was intimacy at all levels was affected by symptoms of GSM. When they actually looked at the data for the UK, they saw a slight difference for the UK women compared for the women in Europe. And the interesting thing that, I think we all need to be aware of, that women said that they expected their doctors or healthcare professionals to talk to them about vaginal symptoms at the menopause. They expected that clinician to initiate a conversation. And yet when they were asked how many of their clinicians actually did that, only 5% of them said that clinicians initiated that discussion. In the UK, there were fewer women on any sort of treatment and more women on over-the-counter treatment than on prescription treatment. But satisfaction with all forms of treatment was actually very low. Only 44% of people were satisfied with the treatments that they had, with women who were using over-the-counter lubricants and moisturizers saying that they didn't find them effective, and women who were on prescription medications saying that they found them messy, but more importantly, that they worried about the risks of using prescribed products. when we look at what happened to UK women and how good they were at accessing healthcare, perhaps not surprisingly, they weren't very good at accessing healthcare. And fewer UK women went to their healthcare professionals for gynae reasons in the year prior to this study than in their European counterparts. It was only about half of the women in the UK had visited, whereas abroad, about 50% had been and asked about gynae symptoms. And in the UK, only 45% of women actually discussed their vulvovaginal symptoms when they went to a consultation. So the UK women waited longer to seek help. And then they didn't always speak up once they got in the room either. So it really reminds us that we need to be initiating this conversation when we're doing smears, when we're seeing somebody with a urine infection, when we see any perimenopausal woman. So I bring you back to that slide. I think it's a rocket lolly, isn't it? And it's sort of red and hot and sore and burny. And these are really, really common symptoms of genitourinary syndrome of the menopause, but a reminder that it's not just about vaginal symptoms. This is about bladder symptoms as well. And that's really all I wanted to say. I want to hand over to Laura, who's going to talk a little bit more about the experience in primary care. Thank you, Laura.
Hi, everyone. Can you hear me? Yeah, that's good. Right, let me just.
I need to end my share and.
I think I can do it. Can you see that? Yeah.
Yep.
Okay. So there might be a little. Oh, well, I'm Laura Crawley. I'm a GP at Bleedless Medical Centre. Recently, over the last 2 years, I've been training. Well, 1.5 years been training with Sue at Jessop's. And I'm no longer training there. I've got my advanced certificate and qualified as a menopause specialist. And Lindsay's qualified recently too as well. So I'm going to talk about my experience of genitourinary syndrome in general practice and how I think we can change things and make women's experience a little bit more smoother, if you like. There might be a bit of overlap with Sue's presentation, but I can skip some of the things that she's gone through and maybe just repeat some of them because it helps, I think. Genitourinary syndrome of the menopause, or what was called vaginal atrophy, and some people still call it that, it affects 50 to 80% of menopausal women. We don't know the exact prevalence because it's underreported, as Sue has told us, and healthcare professionals, we're not asking the right questions always, and women are waiting for us to ask it, and they find it really hard to just openly disclose it without us asking the questions to start off with. This slide is a bit of a repeat of what Sue's been through, comparing a premenopausal vagina with and uterus and the genitourinary tract with a postmenopausal one. And as Sue said, the vaginal lining is thick and moist in premenopausal, and postmenopausal it's thin and dry. And on the right is the box of symptoms that Sue's been through. And as Sue was saying, one of the things that I'm seeing so much more, and I'm more aware of it now because of the training, is women with recurrent UTIs in general practice. And it's really highlighting the fact that these women have the recurrent UTIs, but also lots of other symptoms as well. So the superficial cells in the vagina, they should shed every 4 hours, and that's in a healthy vagina. And they shed, and once they shed, they provide the glycogen that supports the lactobacilli, which are the healthy vaginal bacteria. And all vaginas have other bacteria, which are mostly bowel bacteria, such as staph and strep and mobiluncus. And in GSM or urogenital atrophy, where there's reduction in those superficial cells, there's a reduction in the glycogen, and then there's therefore a reduction in that healthy vaginal bacteria, the lactobacillus, and that's when the other bacteria overgrow. And if we consider that one of the signs of urogenital atrophy or GSM is where the urethra can become more prominent in women, this is in when women already have a short urethra. That's when we see that there's a risk of increased urinary tract infections. And in general practice, I really think that nurses, especially because they're doing most of the smears, are in a really good, and lots of the, seeing lots of women with recurrent UTIs, they're in a really good position to make the majority of the diagnoses of GSM. And I'll come back to smears, but a lot of women we see are having really bad experience when they have their smear because they're so sore. And it's in some of the talks I've been to and some of the lectures I've been present at, it suggested that we might try and contact women before they come for their smear. I don't know how practical this is, especially at the moment. It's difficult because we're so stretched. But just asking women before they have their smear, are you suffering from any of the symptoms of GSM? Because if they are, trying to go ahead with a smear is going to be impossible. It's going to make them have a really bad experience and be in pain, and then it's a vicious cycle because they won't want to come back for their smear again. But if we treat them for 2 or 3 months with some vaginal estrogen, it can make their experience and also treat their symptoms, obviously, and that's a really good time to pick it up. So the role of a healthcare professional, and these figures are from the REVIVE study that Sue was talking about. More than 50% of women expect their healthcare professional to initiate a conversation to inquire about menopause-related symptoms. And as Sue said, only 5% in the UK of healthcare professionals initiate this discussion. And they, as I keep saying, patients really want us to bring this up, and you can see there, and I'm sure you've seen experiences as well, see their relief when you actually ask questions. They're absolutely desperate for somebody to talk to them about it. They feel embarrassed and that they're the only ones who are suffering from these symptoms. So as I said, when to pick it up. So at or before a smear, asking patients questions who are recurrently presenting with UTIs. And in an ideal world, going forward, if we had all the time in the world to develop protocols, patients who are admitted to care or residential homes would be asked questions about GSM and treated with vaginal estrogen, and we could prevent a lot of their recurrent UTIs, potentially falls, and make them comfortable. But I don't know how many women at care or residential homes are asked. And it's something that could be asked at continence clinic appointments, falls clinic appointments, and in secondary care, for example, they could be asked after admission with delirium or urosepsis, falls or recurrent UTIs. And as I said before, when we're treating women before a smear, I think give at least 2 or 3 months of vaginal estrogen, not 2 weeks, because it's not going to make much difference in 2 weeks, unfortunately. It's going to take 2 or 3 months for them to really notice a difference, because if they've struggled to have sex, or they're in pain, or they can't sit down or can't walk, having a speculum put in is going to be one of the most horrendous experiences they're going to experience. And it's, I think, giving them 2 or 3 months to delay it won't be a problem if they can have a satisfactory smear, because we'll get enough cells that way. We've recently in our website at Gleedless, Jez has helped me link the menopause symptom questionnaire, which was developed by Dr. Louise Newson. She's adapted the climacteric green score, because the climacteric green score that we might have all seen doesn't have the symptoms of GSM at the end, but the one that she's adapted does. And if patients ring up reception at our surgery, they are then sent a link to the website. They're able to answer these questions, and then that gets sent through to me and it gets put on their notes. And then we've got a bit of an idea about what some of their symptoms are, and it gives them a bit of space to write. I know I was lucky because he's quite techie, so he was able to do that for me. And they're able to put some of their symptoms in, that can highlight problems before they come and see us, and it saves time as well. So we don't always have long appointments for these women, and that's tricky because it's not going to take just a 10-minute appointment to sort these symptoms out, unfortunately. So questions to ask. One of the recent lectures I've been on is slightly one of the opening questions, and that's we've got a British Menopause Society conference going on at the moment, and we have remote lectures for that. And one of the talkers suggested asking when did you last have sex as an opening. Some might find I think you're going to have to pick your patient to ask that, because as Sue said, it's not all about sex. Some women, there's lots of questions written down there, and as you said, so painful sex, itching around your vagina or vulva. Have you noticed any urinary symptoms such as increased urination, urinary frequency, or being able to hold your urine for less amount of time? Is it sore, burning, or irritating? Does it hurt when you pass urine? these women don't always need investigations, to be honest. We can treat it over the phone. Ideally, they need an examination if we can offer that, but we can, once, you know, if we speak to them over the phone about it, we can initiate treatment. It's safe, and Lindsay's going to talk about that in a bit. So giving vaginal estrogen is safe, and we're not going to do any harm by starting treatment before investigation, unless obviously they've got horrific vaginal bleeding, which they might need a 2-week wait for. But a bit of spotting could potentially be treated with some vaginal estrogen, because it might be some inflammation caused by genitourinary, you know, because of the atrophy that's causing soreness and spotting. But you might want to do, so investigations is often diagnosed as smear taking. For the vast majority, it's not necessary, but you might want to do a urine dipstick, a microscopy for urinary symptoms. As I said, refer for abnormal vaginal bleeding. You might want to do a swab for vaginal discharge. And in the NICE guidelines for suspected cancer, if women have odd discharge, it's completely different to what is normal for them, and you have to make a bit of a decision about this. They're age 55 or older, and they've had these symptoms for the first time and report hematuria, then you might want to do a 2-week wait. But in the vast majority of women, they don't need investigations. So Jane Lewis she's not a healthcare professional, but she's suffered with vaginal atrophy, and as a result she's written a book called Me and My Menopausal Vagina, and that's where the picture came from Sue's slide. And this is a really good leaflet, which I send the link out to for patients, because it's got lots of information on there. I recommend the book as well for them to read, and it makes them feel less alone, that they're not the only ones suffering, because it can be really isolating having GSM, and it can really affect their quality of life. So on the other side of the leaflet, it educates and empowers women. It tells, because lots of women don't know what their vagina and their vulvas look like and what it used to look like, and it's so it's giving some information about that for them to know how to discuss it with their GP. Unfortunately, whenever I try and Google it on Sheffield on the GP computers, it won't let me because it's got vagina in there. So to find it, you put mymenopausal-vagina.co.uk/leaflet-downloads, and I text that to the patient, and then they've got some information, and I quite like it's not too medicalized as well. I quite like that leaflet to send to them. So I've got a case study from as part of my certificate that I did. I had to do a piece of writing, and also because of what I was learning as part of the advanced certificate, I found I was picking more patients up, and I realised that more and more of them were suffering from GSM, and it wasn't just a recurrent UTI. So this lady, she's 78 years old. She presented in August 2020, and she presented to one of our registrars with cystitis, which was getting worse. And due to the pandemic, obviously, we were consulting her remotely, and she described a very sore vulva and vagina. And she disclosed, and obviously our registrar had asked the question, which was brilliant, and she'd stopped having sex with her husband 10 years previously. And the registrar brought her in and examined her and found, and she documented in the notes, a shrunken sore vulva, thinning skin, sore inflamed areas at risk of fissuring, and she wrote clinically it looks like atrophic vaginitis, and she started treatment, estriol, so which is 0.01%, and that's what used to be called Guyaness, but we don't have it as a trade name anymore. Unfortunately, this is where quite often happens, that she's done exactly the right thing, but then the patient's gone away and read the leaflet, and that's made my colleagues doubt their decisions in prescribing. So this is an example of the Guyaness leaflet. I couldn't find one of the current one, but they're all really out of date. They contain completely misleading information, and it's wrong, basically. The patient had suffered from a deep vein thrombosis in her arm about 40 something years ago. It wasn't coded in the notes, so it didn't flag up. However, so she spoke to our GP registrar, and then they spoke to a more senior GP, and it was decided that we'll stop the cream. And she was due to have surgery a few weeks after as well. And I think they felt, because of this leaflet and going through it with the patient, maybe it was a bit too risky to use it. But as we know, there's hardly any contraindications of treatment for GSM, and this leaflet is completely wrong. You can give it with patients in patients who've had a DVT before. Hardly any of the cream will be absorbed systemically, and just like transdermal HRT, which we give in part of, through the like estrogel or transdermal HRT, systemic HRT, it's fine to use in somebody who's had a DVT, and it doesn't need to be stopped before surgery. But luckily, they discussed it with me, and then I started the patient back on. Just for an example, another thing that happens. Say if we were to prescribe Lacell, this is still happening, obviously on EMIS. Say if a patient had a deep vein thrombosis, it will flag up and say it's contraindicated, and it says topical estrogens are contraindicated with venous thromboembolism, and that's wrong. But that's going to make somebody who isn't as confident in managing the menopause wary about prescribing it, and then doubt themselves. So no wonder sort of women aren't getting the right treatment, because we've got all these systems which are against us and making us doubt ourselves as GPs as well. So the outdated leaflets tell patients not to read it. It's completely wrong. It doesn't have the correct information on it, and try and ignore EMIS when it flags that up at you. So I contacted the patient, I reassured her, and restarted the treatment, and we've tried various ones over the following weeks and months. Unfortunately, it's not always one size fits all, and some women work better with different treatments, which Lindsay will talk about. I also reviewed her medical records out of interest in part of my piece of written work, and she'd been prescribed 19 different courses of antibiotics for presumed UTIs over the previous 12 months. And looking back further through the record, since the 5th of September 2011, she'd had 35 different courses of antibiotics for recurrent UTIs. So she'd had this issue for a long time, and it was only flagged up when I looked at her notes. I think as a result of this, one thing that we're going to try, which we're in the process of doing at the surgery, is developing what you'd call a concept in EMIS, where if a woman over 50 is prescribed an antibiotic for a UTI, it will flag it up if this is a second antibiotic in the previous 6 months. So it can ask the question, have you considered GSM if we're currently prescribing antibiotics for women? And I think that's quite an easy thing to do as GPs on a system, and it can make us think of this question. And as a result of the study, I've done some training and teaching at the surgery, and I'm finding now that, especially from the notes and with the nurses and our advanced nurse practitioners, when they're doing triage, they're really starting to flag up these women, and then I'm signposting them to myself, and we're starting to get much more women on treatment, and obviously get them a lot more comfortable and reduce their symptoms. And I think that's really gone on board with having the teaching similar to what we're doing today for everyone here. And the more we ask the questions, the more they become second nature, and having questions flag up on the system makes it easier to remember, because we're all really busy, and sometimes it's quite easy just to say, oh, I'll just prescribe some more antibiotics for UTI, and that's that case done. But we could rebook them in for another appointment to discuss it. You don't necessarily have to do it there and then, but it's something to flag up with women when you can. So the British Menopause Society vision for menopause care in the UK, that was updated in October 2020, and it outlines the steps we must take in order for all women to access good quality menopause care. And it states that there's a notable lack of UK-wide provisions for menopause services, and that's due to pressures on Department of Health and Social Care budgets, and it's having a seriously detrimental effect in addressing midlife women's health and well-being. NICE have actually developed a decision aid, and on part of that decision aid, it's looking at ways that we can reduce the chance of recurrent UTIs in postmenopausal women, and it mentions on there you might like to try vaginal estrogen, and it's off-label, it's not licensed specifically for preventing UTIs, but we know that we prescribe a lot of things in medicine that are off-label, not licensed, but we know that they can work. And it goes on to list figures. If 100 women use vaginal estrogen, we would expect over 8 months on average, about 40 women won't get a UTI, but would not have done anyway. 45 women avoid getting a UTI because they're on vaginal estrogen, and 15 women get a UTI even though they use vaginal estrogen. So 40 women wouldn't get a UTI anyway, 45 avoid getting it because of the vaginal estrogen, and then the smaller amount of 15 women get a UTI even though they're using the vaginal estrogen. And as I said, so developing the concept triggered for EMIS, flagging these women up, would be really handy, and we can discuss whether they'd like to try vaginal estrogen if they've got other symptoms of GSM especially, and it gives us that chance to ask that question. The decision aid also looks at using antibiotic use in recurrent UTIs, and it suggests similar figures as estrogen, but you weigh up the risks of giving lots of courses of antibiotic or prophylactic antibiotics and what the risks of that might be. So it is a decision to be made with the patient. So I've just got a few other patient case studies. One's actually from somebody that I follow somebody on Instagram, and this lady popped up, and it's quite interesting because it's in all women, even women who have a professional background in medicine or so I couldn't play this unfortunately because I didn't know how to do it with the sound. So I'm going to read out what this lady said. So, hi everyone, I'm Fiona from Harley Street Emporium. Now I'm 56. I've been menopausal since I was 51. I have a degree in anatomy and physiology, and I've spent the last 18 years writing for medical magazines, which either go to doctors or to consumers. In all that period of time, nobody told me that the little bit of vaginal dryness or burning or itching on my external genitalia would develop into something that is quite debilitating. It made walking difficult, it made sitting difficult, and it made having sex nigh on impossible. My big mistake, of course, was to continue to self-treat, thinking it was thrush, when it certainly wasn't, only to discover when it got extremely debilitating, I found out it was vaginal atrophy. What has saved me is this little cream, Avestin, and I would urge other women to do what I'd urge other women to do is not what I did, and please don't self-treat, get help. And some patients from a clinic which I was doing last week, just a few quotes just from Thursday last week. So one lady said, I don't feel womanly anymore, it feels dead down there. Another said, I can't walk for more than an hour without having to find a bush to wee behind. Going for walks with my friend is my hobby. On a 4-hour walk, I have to run to a bush about 4 times, which is really embarrassing. Another lady said, I feel like I've got nettles in my underwear, and I constantly feel like I've got nettles in there and I can't sit down. One lady has already started on estriol, she's already started to notice a difference in her incontinence on sneezing, and using the estriol alongside her pelvic floor exercises has made her symptoms so much better. So we know that it helps, so that obviously there was lots of women who struggled, but one lady had already started treatment and she started to notice a difference. And finally, as Sue was saying, we know it's not just in post or peri or menopausal women. You can also get a sudden drop in estrogen levels when you give birth, and these can continue to stay low when you're breastfeeding. And lots of women can suffer from genitourinary symptoms on breastfeeding as well. So you can get vaginal dryness, vulval irritation, and the same symptoms as GSM. And we can treat those ladies with vaginal estrogen. There's some thought that estrogen cream can lower, affect milk production. So some consider it more, there's not really enough research on it basically, but some say wait 6 weeks. But I suppose you can ask them how severe are their symptoms. And it might be something that we want to ask at a postnatal check. If a lady's breastfeeding, especially IMH, I ask them about symptoms, genitourinary symptoms, because we can easily treat it with vaginal estrogen. And that's me.
Okay, so I'm just going to try and share my screen now. So Sue and I have managed to choose the same slides, which makes it look like we planned that earlier. I'm just trying to go to slideshow, sorry. Which I don't think I can get to. So I'm going to talk about treatments, and treatments, like everything that we do with anything to do with the menopause, needs to be really individualized, and we need to be asking questions about what women actually want. What are their symptoms? Are they having lots of bladder symptoms? Are they only having vaginal dryness or noticing it when they're having sex? Or do things feel generally uncomfortable? Is it just the vagina and the introitus, or is it more vulval tissues as well? And then tailor it to that, because there's different treatments might work better for some symptoms than others, and some women might need combinations of treatments as well. So I think it's really good to start with basics and talking to women about things that are non-hormonal that might help. So lubricants are obviously really important for helping during sex when women's natural lubrication has started to reduce, like Sue was describing. And there are lots of different types of lubricants, and women will often, if they're just grabbing something quickly or you've gone to the supermarket, there'll be KY jelly, there'll be highly scented and perfumed Durex type lubricants. And actually that can make the situation an awful lot worse because it can be really irritating. So it's good to talk about choices of lubricants, and women will often find that one suits them better than another, and that's just a little bit of trial and error. And it's good to talk to people about buying small sizes of them. Often in clinic we will have samples of things that we can give, but if obviously we don't have that in general practice, so it's good to advise women to perhaps buy a couple of small sizes of things and try and see what suits them. So water-based lubricants are good because they're a very gentle lubricant. You can use them with condoms. They're quite easy to wash off afterwards, which might not seem very important, but some of the other ones can cause irritation if it's quite difficult to get rid of all that lubricant. They can dry up quite quickly, and sometimes they don't provide enough lubrication. So that's when things like an oil-based or a hyaluronic acid-based lubricant might be better. They are really useful for sex. They provide really temporary relief of symptoms, and they will need to be applied every time. Sometimes women find it helpful to apply them before sex, or applying it regularly can actually make people feel like things feel more normal, and that can make people feel more like they want to have sex as well. There are different types, as I was saying. Yes is a really good brand, and they do a water-based and an oil-based lubricant. Silk's another water-based one that you've probably heard of, and there's one that's talked about quite a lot at the moment, which is called Sutil Lux, and lots of women are getting on really well with that as well, and that is water-based. Things to advise women to use would be anything with glycerins in, parabens in, or petroleum jelly type based products like Vaseline, because they can be really irritant and can actually cause infections. Moisturizer is a really good option, and like moisturizer anywhere, they're basically going to plump up the tissues, bring fluid into them. They adhere to the vaginal wall and actually draw water in and restore the vagina's natural acidity as well. The recommendation is to use them sort of 2 to 3 times a week. They come in different packaging, but mainly in an applicator that you would insert a couple of times a week. But women can use those every day if they felt they needed to. Some women might find that's enough, but lots of women, as Laura and Sue have talked about, are going to really benefit from using hormones. Other things that are really important are how women look after their vulval skin. So there's lots of feminine washes out there, lots of things which would draw people in to think that might make that area healthier, but actually they're likely to be really irritating. Water is enough on its own, or using emollients, things like dermal wash, things that we would use, that we'd advise to people who have got any skin conditions and are using as a wash. Obviously, vaginal estrogens are going to completely restore the vagina, or do a good job of restoring the vagina to how it was premenopausally. And it is really important to separate vaginal estrogens from systemic HRT, because it's a completely different thing. And the leaflets that do come with them apply to, well, don't apply to all forms of systemic HRT. Largely they apply to oral HRT, but they talk about thrombosis risks, they talk about breast cancer risk, they talk about stroke risks, liver disease risks, none of which apply to using estrogen vaginally. And I think that's really important to talk to women about the leaflet. I would always tell women they can read the leaflet if they want to, but I wouldn't, because it's not actually reading about something which applies to the treatment that you're using. You also don't need, I'm sure everyone knows this, but you don't need any endometrial protection with vaginal estrogens, because there's not enough being absorbed to cause any thickening of the lining of the womb like you would with systemic HRT. So vaginal estrogens are largely low dose, and they do come in different doses. So there are some products which are ultra low dose now, which can be really helpful. And although you will get some systemic absorption, that usually only lasts for about the first 8 to 12 weeks. That absorption tends to be greater in women who've got really atrophic, really thin tissues, because there's more chance of it being absorbed and getting into the bloodstream. And choosing which dose to use will really depend on what sort of product a woman wants to use, or what her other sort of comorbidities are. And I'll come on to talking about breast cancer in a minute. So I think with vaginal estrogens, we can often think of it as just being cream or just being a pessary, but there are different options of creams and pessaries to use. And it's worth talking, it's very important to talk to women, as I said, about what are their symptoms. So, and what sort of product are they looking for? So are they going to mind if they're inserting a applicator full of cream and that's going to be leaking out? Some women might find that really messy and not like the thought of it. Other women, if they've got lots of vulval symptoms, actually that cream leaking out and coating the vulval areas can be really helpful. And often women will need a combination of treatments, and that is absolutely fine to use because they are low dose. So you wouldn't perhaps go for that first line, but if something is providing, for example, if you're using a pessary and that's really helping with vaginal dryness, but they've still got a lot of vulval soreness, you might want to add a little bit of cream in with that. So I'm just going to share. So Sue has been involved in writing a document for the British Society of Sexual Medicine, and actually I think it's one of the best guidance talking about all the different treatments, how you start them, what the advantages and disadvantages of them are. So we're probably all really familiar with Vagifem, which is obviously a pessary that you load up using it every night for 2 weeks, and then after that you would reduce to using it 2 times a week, and that should be enough to hold things. Vagirix is a
Lindsay, I'm sorry to interrupt you. You need to share the. Have you shared the? I know you're reading off that screen, aren't you?
Yeah. Can you not see it?
I can see your PowerPoint, but not the BSSM
Oh,
table.
hang on. Sorry, I'm really sorry, everyone. I'm not necessarily the best with this. Let me go back to my PowerPoint. So do I need to stop sharing again?
I'm just, yeah, and then you might be able to pick up the.
Do you know, we've talked a lot actually. Does anybody want to ask any questions in between before I just fire through all of those treatments? It might be a good time for people to just ask questions, and then we might be able to answer questions about treatments as we go along.
We've had some questions. So Farida had asked about names of lubricants that work, and Marion had suggested yes, Pure spelt with a J, Replens and Silk. Are there any others?
So there's one that I've come across quite a lot recently called Subtle Lux, which women seem to like. That's water-based, but the ones that Marion has suggested, I don't know about Sue and Laura, I would normally suggest yes is brilliant, and Silk.
Okay.
I certainly would suggest yes, and often the combination of using an oil and a water-based lubricant at the same time is supposed to do this technique called double glide, so that the two slide together, and it's supposed to be really helpful. So the guy can put the oil-based on and the woman can put the water-based on, or vice versa, and it produces this gliding sort of action. The other thing that I would say about yes is if you go to their website, they'll send you free samples. So if somebody's wanted to try something, then that's a really good option.
Okay. And then Lizzie Lisbury has asked, and I have to confess I remember this from my gum days, that they've had aqueous cream suggested as a moisturiser from Gynae Clinic, but I know the dermatologists hate it. So is there a definitive answer about aqueous cream?
Yeah, so it's not suggested as a wash, the same as it isn't suggested, as it's not suggested by dermatology anymore. It's not great to use on your vulval area.
Okay, let me just go further up. Don't think anybody else has. The other questions are more general menopause, if you want to take those now, or if anybody has any other genitourinary questions.
I think it would be really nice to cover some of the newer products, Lindsay, because like you say, people are familiar with Vagifem, but not as familiar with Vagirox and Invagis, Intrarosa, those things.
Bring it up now. Has that shared now?
Yes.
Yeah.
Okay.
One more question. Sorry. Angie Mitchell wants to know, what wash would you suggest rather than aqueous cream?
So I suggest dermal, but I don't see, what do you suggest?
Tetraben, or I often just put it back to the GP and say whichever emollient wash you prefer to prescribe, but not aqueous cream. The studies on aqueous cream were done on women with atopy. They suggested that using aqueous cream actually dehydrated the skin, and it was only in the group of women with atopy. But I think, you know, so many women are atopic, it seems ridiculous to use something that's greasy and not that nice to use anyway, and may actually dehydrate the skin.
So sorry, before I thought everybody could see this rather than me just rattling off talking about treatments. So yeah, we're probably all familiar with Vagifem. Vagirix is the same as Vagifem, it's just more eco-friendly. So instead of having and it's much cheaper. So instead of having a new applicator with every pessary, there's a reusable applicator. Vagifem can actually be used, so you would say that you'd use it twice a week, but people who have been a GP as long as I have, or longer than I have, will remember that Vagifem used to be a 25 microgram tablet. So when that was used twice a week, you actually used to get more than you are getting with using it twice a week. So in women who twice a week doesn't help their symptoms, it is okay to use it sort of 3 to 4 times a week. And then there are, so Vagifem, Vagirix, and then the creams, Ovestin and Estriol, are all of a similar sort of strength of dosing. The difference between those would be, obviously, they're different types of estrogen. So Vagifem is estradiol, and Ovestin and Estriol are estriol. And that just depends on whether women prefer a cream or prefer to use a pessary. And that largely depends, like I was saying, on what symptoms they've got. But you can use a combination of those. So you might want to use some Vagifem with a little bit of Ovestin on the outside. What's good to know about Ovestin and estriol, one is that estriol contains peanut oil. So if you've got anybody who's got any nut allergies, it's good to avoid that. Obviously, you need to avoid that. And estriol, if you're choosing between those creams, sometimes Ovestin can be a little bit irritating, and women tend to find that estriol is less irritating. In terms of newer products, the ones that are probably the most interesting are the really low, the ultra low dose ones. So there's a pessary called Invagis, and there is a gel called Blissel. Invagis is like a little bullet type pessary that you just pop inside with your finger, and Blissel is a gel which comes in an applicator. They're good as being lower dose for a couple of reasons. If you've got women who have got a really atrophic vagina, sometimes they will get a lot of systemic absorption, and they can have a lot of quite a lot of increased discharge as their body reacts to having higher levels of estrogen in that area again. And in older women, so if you're starting women sort of 70s, 80s, that is an option to go for a lower dose estrogen, and they might tolerate that better. Some people who have got really atrophic symptoms will find applicators really painful. And actually, I don't think the applicators are designed very well for women who've got soreness and atrophy, because they can cause a little bit of snagging, or they're quite blunt and they're very plastic, obviously. So sometimes Invagis is a good option because you're popping it inside with your finger. Women can put the tablets, Vagifem or Vagirix, you can do that with your finger, but it won't go obviously as high up. And then another brilliant option, and I really like this, is E-string, which is a small ring that's impregnated with estradiol. I don't know if anybody's seen them. The only way I can describe it to women is it's a little bit like the ridge at the top of a condom. So it's impregnated with the thing, with the hormone, and then you just sort of squeeze it and pop it inside, and women can do that quite easily themselves. Some women want to have it done the first time. I often put them in for the first time for women, and then they have a practice, and that only needs changing every 90 days. You can leave them in to have sex, or women can take it out, give it a rinse, and then pop it back in afterwards. And I suppose while we're talking about sex, with creams or with Vagifem or any of the other products, it's good to leave it you need to leave it a couple of hours after inserting it before women have sex, because a little bit will transfer. And then a newer product, which I don't know how much Sue and Laura use this. I've used it a few times, is Intrarosa, which is actually DHEA, which is then absorbed and converted to both estrogen and testosterone. So it can help. I've used it in women who haven't seemed to respond very well to anything else, or women who are having a lot of problems with responsiveness and sort of feeling like they want to have sex, or that things are responding in a way that they would want to, because that extra conversion to testosterone can help a little bit with that as well. Sue and Laura, is there anything you wanted to say about those treatments?
No, I think you've hit the nail on the head. It's about asking that woman what she wants to use. How dexterous is she? Is she going to be able to use an applicator? You know, if you're going to use an applicator with a cream, there's a mark on the applicator which shows you how much cream you need to have in the applicator, and sometimes it's quite difficult to see. So I think it's about getting the right product for the individual, and it might change. Somebody might be very dry and uncomfortable and want to use a cream at first, and then when they're much more comfortable and have got a bit of confidence, they may prefer to move away from something that's quite as messy, maybe towards something more like a Vagifem type product. And I think the other thing to point out is that women who are on systemic HRT also need vaginal estrogen in many cases. The data says about 1 in 5 also need to use vaginal estrogen, and I'm often asked, is that safe? Or my GP says I can't have both, it's too much estrogen. Absolutely, it's normal to need to use vaginal estrogen alongside systemic HRT.
Yeah, absolutely. I think it is. Yeah, sort of, yeah, it's a 10 to 20% of women, isn't it? It's a lot of women who need both. And just to echo what Laura said as well, is that women are very happy to talk about their other symptoms, their hot flushes, their night sweats, the anxiety, all of those things. But often women don't mention the vaginal symptoms unless you actually say, and how do things feel? Does it feel different when you have sex? Do things feel sore when you're wiping? Are you getting up at night to go for a wee all the time? You've got to ask those questions, otherwise women don't mention them. I'm just going to go back to my slides. So I was going to talk about breast cancer a little bit, because although systemic HRT is obviously a specialist area with prescribing, it's vaginal dryness in women who've had breast cancer is something that we're probably all asked a lot about in primary care. And as we've talked about, the symptoms from vaginal dryness, it's not only when people are having sex, although obviously that's really important. It can get to the point that people can't sit down, they can't wear knickers, they can't ride bikes, they can't do all sorts of things, even walking. So it can be really debilitating. And for women who survive breast cancer, their estrogen deficiency symptoms can be really debilitating. Dryness is really common with aromatase inhibitors, with tamoxifen, and also after chemotherapy. And it's estimated that about 50 to 75% of women will have quite significant symptoms. They tend to be more severe with aromatase inhibitors, as all estrogen deficiency symptoms are. You would absolutely go for non-hormonal treatments first line. And I think it's really good to talk to women about vaginal dryness and these treatments. early on in their treatment, because the earlier that you get in there and try and help and try and soothe things and keep the vagina as healthy and as lubricated as it can be, the better impact that's going to have. And we have been talking with the three of us have been talking with the oncologists recently to try to do some education around that with the breast care nurses, and perhaps provide some better leaflets to women so that they know what their options are. There is lots of evidence to support the use of the safe use of vaginal estrogens in women who've had breast cancer, in terms of that minimal absorption over the first weeks when you're using it. We know that vaginal estrogens don't increase the risk of breast cancer in women who haven't had breast cancer. But the safety data is really limited. Studies that have been for really short periods of time. So we don't really know over long periods of time what impact that's going to have. And it may be that even though on standard blood levels that we would do looking at estradiol levels, it might not look like there's been any increase. If the oncologists do sort of more sophisticated testing, they can see tiny increases in the estrogen. And if there were any sort of micrometastases anywhere, obviously that's going to be an issue. So when we're talking to women about using vaginal estrogen, it's absolutely an option, but it's about them very much understanding what that means for them. And hopefully we'll have some better leaflets in Sheffield soon to make that easier. At the moment, the advice from the British Menopause Society would be that it needs to be discussed with the oncology team, and that's very much what I'd recommend at the moment. But we are hoping that we can produce more of a protocol between sort of menopause specialists and the oncologists to make that easier in primary care, because oncology get asked a lot about that, and actually it's probably a decision that we can make ourselves with women in primary care. Obviously you want to try and go for the lowest dose possible. So the pessary I talked about in Vagus is a good option, and also Blissell, and estradiol is thought to be slightly less potent than estradiol options. And it might be good to look at when we're not certain at the moment, but it might be good when we're looking at those 2-3 weeks of loading doses, that perhaps we should make that a little bit lower dose. Perhaps we should look at alternate day dosing as well, just to reduce the systemic absorption a little bit more.
Lindsay, there's been a question. Is this patients who've ever had breast cancer or just current breast cancer patients?
It would be any patients who've had breast cancer. Obviously, the decisions that you make about treating women with any form of estrogen when they've had breast cancer, the further the way they are from that diagnosis, the safer, well, the better that feels, the closer women are to their diagnosis. And depending on what their diagnosis has been, how severe that diagnosis is, what their options are, what treatments they're on. But yeah, it does apply to all women who've had breast cancer. So I don't know if there are any more questions. I was just going to round up by things that I think are good to know. I've said them probably already. Estradiol has peanut oil in. Ovestin can be more irritating than estradiol, but it's good to know between those two creams that although there'll be different strengths because of the amount you use, they're actually the same. They're different concentrations. The strength is the same when you use them. Ovestin is a tiny amount of cream, and estradiol is a good applicator full of cream. So in terms of how messy that's going to be, estradiol is going to be a lot messier. They can lead to increased discharge when women are first using them, and I think that's really important to warn women. And women might also they can get symptoms of thrush, because when you're introducing a high level of estrogen back in, we know that high levels of estrogen are a breeding ground for thrush, so it's good to warn women about that as well. And you can get on and treat that, carry on with the treatment, and it's no reason to stop using, because it should settle down with time. As Laura said, we need to be realistic about using estrogen before smears. You often hear that it's just used for a couple of weeks. Women who've got atrophy need to be using vaginal estrogens a good 2 to 3 months before they have a smear for it to be genuinely comfortable for them. And then just to add in again that the leaflets are worrying and they're inaccurate, and that it's good to point that out to women. And that's me done.
I don't think we've got any genitourinary questions, but we have got a number of general menopause questions. So do you want to start with those and then see if anybody comes up with other questions while we're chatting?
Yeah, we can do that.
So, right, the first one is, I don't know who sent this in. Their understanding is that in relation to breast cancer risk and HRT, the risk comes from progesterone. So there's no increased breast cancer risk with estrogen-only HRT. So how do the relative risks of different progesterones compare? For example, transdermal versus oral versus vaginal uterogastdan versus Mirena. And they're assuming that there's no risk with Mirena since we don't counsel women about breast cancer when we're fitting it for contraception.
It's a very, very good question and quite complicated. But in general, that's right, that the risk seems to be from the combination of estrogen and progestogen rather than estrogen alone. And some of the studies that have been done, particularly in France, have looked at different types of progestogen, and it would appear that natural micronized progesterone, which is utrogestan, and dydrogesterone seem to have the lowest impact on breast tissue and the lowest risk of breast cancer. I'd have to say that they're not as huge as some of the other studies that have been done, but certainly that would be my advice if you're looking for something with the lowest risk of breast cancer. The question about the Mirena coil is also an interesting one. There have been studies both done on women who are using it for contraception and for women using it as part of their HRT, and there's been conflicting evidence. Some have shown an increased risk of breast cancer for users of a Mirena coil in either situation, but there isn't enough evidence that's clear to be able to share that really usefully with anybody. So yes, I think you'd have to say that using a Mirena coil would increase your risk of breast cancer, certainly as part of HRT and possibly as part of contraception.
I think it looks like when you look at we all know that there is some systemic absorption of Mirena, although that reduces with time. And when you look at the actual blood levels that Mirena gives you, it's probably comparable to a transdermal synthetic progestogen. But I think we all have to remember as well that still the risk of breast cancer for most women is really low with HRT, and that lifestyle plays a much big factor in women's risk of breast cancer. So the differences between the synthetic micronized progesterone does look like it's safer on those studies that have been done, and possibly doesn't have any increased risk for the first 5 years of using it, but they're not as big as the big randomized controlled trials that have been done. So yes, micronized progesterone probably is a little bit safer, but the synthetic ones aren't not safe.
Okay. Next question is, and I have to say this is something I know has come up through gynae cases, and I can't recall what Mary said. Is progesterone pill sufficient to provide endometrial protection in HRT? So if you've got a perimenopausal woman on the progesterone pill for contraception, could you just add in some transdermal estrogen? And if not,
no.
why not?
No, it's not enough. So you could either, if they want the contraception, you could swap to a Mirena, or you could add it, or you could use utrogestan alongside the desogestrel off license. I don't know what Sue and Laura are going to say. Off license, you can double up the desogestrel, but that wouldn't be. I do that sometimes, and if women don't bleed with it, or if they've not been bleeding with the desogestrel, then it will probably provide enough endometrial protection. What do you think, Sue and Laura?
Yeah, no, I've certainly done that too, but I would be more likely to be encouraging someone to have a continuous combined HRT with their progestogen-only pill for contraception alongside it. You know, they're likely to be amenorrheic on that combination, so that would probably work quite well. But if for some reason they couldn't do that, then yes, out of license you could double up, but it's getting a little bit more specialist if you're looking at doing that.
Okay, Sally and the 4 people in Woodseats are having more and more queries for women under 45 with perimenopausal symptoms, still having regular periods, and they would be grateful for advice. I don't know if Sally and the Woodseats people want to unmute and elaborate on that.
I'll unmute. I can't turn the camera to face us, so I apologise. But no, it just obviously since the Davina McCall programme, which I'm sure people are aware of, we've had a lot of HRT queries, which I'm sure everybody else is experiencing exactly the same. But we are getting women who are asking to start on HRT below the age of, the age that we would usually kind of be expecting, sort of, menopausal, or we were expecting to start treatment, and just wondered really what the kind of advice was. They're definitely getting symptoms of, brain fog, flushes, sweats, maybe a little bit of irregularity in bleeding, but still getting bleeding. So just wondered really what the thoughts were.
So in my experience, I go through the menopause symptom questionnaire, like you're saying, they're ticking off a lot of the boxes. And just because they've not stopped their period doesn't mean they're not having massive fluctuations in their hormones and drops in estrogen. And we can still, so it would be to start treatment and you would give it cyclically, but you need to discuss that with the women, and they don't have to reach a certain age for you to start the HRT. You do it on a discussion with, about their symptoms and what they would like improving, and going through the, there's a lot of, obviously we know there's lots of benefits from starting HRT with bone protection, cardiovascular protection, and it's patient choice at the end of the day. And I think because of the Davina McCall, it's opened up the discussion around it, and more women are going to be coming. And that's one of the reasons we've developed the link on our website, so we can direct them to the symptom questionnaire, and we've got a starting point to have that discussion with women. But we know we can treat women who are having periods with a cyclical regime of HRT, so it's easily done.
And actually, the earlier you start HRT, the safer it is, because in terms of the benefits that HRT can bring, so cardiovascular disease protection, and bone protection, we're going to start losing bone density from our early 40s. So the sooner you get in there and provide that protection, the better, if women are symptomatic and wanting HRT. And if you start it within 10 years of, I know these women's periods haven't stopped, but if you never let that estrogen drop, the cardiovascular protection that you provide is getting in there earlier and is going to be more sufficient. But lots of women will have symptoms in their early 40s, given that the average age of the menopause is 51. If you make that an average, lots of women are going to be perimenopausal earlier.
So there's two related questions. One is, if you have a woman in her 40s who you're considering giving HRT, but is on an amenorrheic form of contraception, should you go for continuous, or would you go for sequential HRT? And then the second question is, do you have to give sequential HRT if they get migraines due to cyclical hormone changes?
I think in that situation where she's already amenorrheic, I would definitely go for continuous combined, because I think she would still have that protection of her endometrium from her mini pill, whichever one she's on, that is making her amenorrheic, and then a continuous combined preparation is only going to add to that. So hopefully she wouldn't get cycles back again. And really you want to avoid any cyclical activity in somebody with migraines, because most of them are hormonally stimulated. So you want to keep hormone dosing really smooth. So, for somebody with migraine, you'd be hoping that you could put them on a continuous combined preparation to really help with the frequency of their migraines.
So in women who are perimenopausal and have migraines and are still having regular periods, actually a Mirena can be really helpful, because it provides that really steady level of progestogen, so you're not going to get those changes. And patches are often better because they provide a stable level of estrogen, a more stable level than gel or a spray.
Okay. Bev has asked, can we use estrogen gel as in the topical systemic one after breast cancer, not vaginal? So I think that's transdermal estrogen after breast cancer as opposed to vaginal estrogen. I
think the short answer is, in general, no. But there are some women who, after lots of consultation, perhaps with their oncologist and with a menopause specialist, will choose to take estrogen because of the severity of their symptoms. And this is looking about quality of life. So if you have somebody in that situation, it's worth checking with the oncologist what their opinion is. I have a woman I saw today who had breast cancer only 2 or 3 years ago, but is thought to have a very, very good prognosis. And after discussion with the oncologist, she has such severe symptoms that she's on low dose estrogen and her life is changed. There's no good living forever if you're struggling with terrible menopausal symptoms and you can't sleep. So all of these things are open to discussion, but the general answer is it's not usual.
Okay.
And there's different options for those women as well, because like we were talking about, a lot of people will be on medication that is reducing their estrogen. So after discussion with their oncologists, rather than adding hormones in, they can look at reducing those treatments, having a treatment holiday from them, see if they feel better. But that's very much oncology led, and then using estrogens in breast cancer is very much menopause specialist led.
Sarah Kellogg was the person who had asked about the migraines, and she said that the lady with migraines, the Mirena didn't help. I don't know, Sarah, if you want to unmute and ask some more questions. No.
Yeah, I do actually.
Oh, sorry.
I couldn't find the unmute button. So yeah,
Okay.
the lady she's had every possible treatment for migraine in the past, and she had premature ovarian syndrome, but with a very irregular bleeding. And she's now getting quite menopausal symptoms, and she's still getting a really severe migraines and a cycle nature. So she saw the programme the other night and sort of discussed about HRT. So I agreed I would start her on it, but I didn't know whether to start on the cyclical because she was perimenopausal, or whether to start on cyclical to actually maintain a sort of steady hormone, because she's not had a full year of not bleeding. So I said I would start transdermal with the Utrogestan, and I said I was coming to this tonight, so I said I would ask tonight about the sort of where to go from here. She's only just started it. She's had sort of started it the last week or so. So it was just really to see where I go from here.
Have her migraines got worse since she's become perimenopausal?
Yeah, she was given she had a really severe episode of heavy bleeding, and she had some progestogen only to sort of stop the bleeding eventually, and her migraines just went haywire after that with the high dose. I actually referred her to gynae, so she is in the pipeline for that, but in the meantime it's sort of the migraine, she's getting them every day now, so it's just a bit of just where to go from here for a while she's waiting for a gynae appointment. So
she might do better once you've actually got some estrogen, although hormone fluctuations can change things. She might actually do better with her migraines once you can actually get some estrogen into her and level things out a little bit, because it might be the fluctuations which are causing the problems. I think if she's having regular periods, if someone's
irregular periods.
How irregular are they? Because I think if someone's not had a period for 7 months, 8 months, then absolutely
not that much. It's about 2 or 3 months.
I think I'd go for, personally, I would go for cyclical, because you're likely to give her irregular bleeding otherwise. So I'd go for cyclical and just see how she is. And if the migraines are worse, then you could try continuous to try and level things out. Or you could always try and stop her ovulating with something like desogestrel as well, and then use the transdermal estrogen, because sometimes taking her own fluctuation in hormones in the background out of it can make that easier as well. What do you think, Sue, Laura?
Well, I think it's really interesting because you have to think, well, why do we reserve continuous combined for people who are 1 year post their last period? What is the rationale behind that? And the rationale really isn't very convincing. It's just to say that we know that you're more likely to be amenorrheic on a continuous combined method the longer it is since you last had a period. So what are the risks of trying it in someone who's only 3 months since their last period? Well, the risk is that they may have more irregular bleeding. So I would have that discussion and say, well, look, these are the options. Theoretically, continuous combined would be better for you, but you may get troublesome and irregular bleeding with this. Which do you feel better able to cope with? And if she was able to try and wanted to try continuous combined, I would go with that. And if she said, I can't, you know, I'm a teacher, I'm in school, I can't come out of class if I suddenly bleed, I want to have a predictable bleed, then I would go with sequential. The other thing that, you know, you might consider, you could give her a GnRH analog, couldn't you? You could completely abolish her cycle and then give her continuous combined HRT. And maybe that's, you know, yeah, it's a province of gynae, but you know, those things really do work well. You would do that for someone with PMS, wouldn't you? And you could do it for someone if her migraine is clearly hormonal and not responding in other ways.
Yeah, in the past, she had premature ovarian sort of, but she's also failure, but she's also had endometriosis way back as well. She had infertility treatment for endometriosis, so she's got a whole host of
Does she have a coil, a Marina coil?
Didn't get on with it, Laura.
past, yeah.
Oh, sorry, I didn't hear that.
Yeah, she didn't get on with that at all.
Oh.
Migraines went worse.
Okay.
Yeah. Okay, so that's food for thought. I will go and have a chat with her about it again. So thank you.
Marion Sloane's remarked that she's found that it's the varying and falling estrogen that drives the migraine. So she had wondered about daily transdermal and cyclical uterogestrin.
Yeah, I think we've just gone through. We're going to suggest continuous uterogestrin and really increasing the estrogen. So don't be scared to give 2 pumps to start off with, and then 3 months later, a few weeks later, you might want to go up to 3 if and see how she gets on with 3. But maybe because some women just try a pump and see how, you know, 1 pump of it and see how they get on, but they're not quick enough maybe to increase on the dose to see if that helps.
Yeah, thank you.
So I think that's all the questions. Unless anybody's got a question I've missed or more questions they haven't written down yet. No, so in that case, I think since it's 8:20 and nobody seems to have any other questions, we should say thank you very much to our panel of speakers. That was excellent, thank you. Really helpful, really useful. And thank you all for coming and listening and asking questions.
Thank you very much for inviting us. Yeah, I've enjoyed the evening, so I hope everybody else has too.
Thank you.
Thank you.
Sarah, yes, we will. The recording will go on the PCS website, and what slides, are we okay to email those out?
I think is it just the BSSM? Was it just someone had put something on about that? But you can, if you just Google the British Society of Sexual Medicine, it's on
I linked it on there, Lindsay. I put the link on.
Okay, cool. Thank you.
Okay.
Okay, well, good night.
Thank you.
Thank you.
Thanks.
Okay.
Bye.
Bye.